Thank you. And hello, everyone. Welcome back from the sponsor break. I hope you all had a chance to stop by the booth and get those tokens collected for this for the game hunt. I'm excited to introduce this next session for the APCD Potpourri. This this session's potpourri probably won't do much for your olfactory, but there's a great variety of topics near and dear to my heart coming right up. But let me first thank Stern Consulting on behalf of NATO for sponsoring this fragrant session. And I'll go ahead and introduce your moderator for this session, Jenn Toms, who is the Director of Business Development with Onpoint Health Data. Thank you for organizing as well, Jenn. And I'm excited and looking forward to the conversation. I'll let you take it from here.
Awesome. Thank you, Charles. So as Charles mentioned, I'm Jenn. I'm with Onpoint Health Data, and I'm very honored and pleased to welcome you to our presentation session. As Charles mentioned, APCD Potpourri is a bit of a fun and ambiguous, maybe a bit, title for a session. So I'm going to build a little bit on what Charles said and maybe offer a slight correction. So for anyone who might not know, potpourri usually refers to, in our modern times, a lovely mix of dried flowers and herbs that add a little bit of fragrance to the home. But I did a little bit of some etymology digging, and it is actually a 17th century French term that can be used to refer to any type of mixture, from a stew to literary or musical medleys. So today you're just going to be hearing from our brilliant presenters on a variety of topics. So what I'm considering an informative mixture of APCD subjects. So with that, we'll get started here in just 1 second. As the lovely lady kicking off this session mentioned, you'll be able to put comments and questions in the chat. We'll pause between individual presenters to address your topic-specific questions before moving on to the next presenter. And then at the end, we should have some time left to address any final questions that you might have for any of our presenters. So with that, let's kick things off. First up for APCD Potpourri, we have Karen Hampton from the Oregon Health Authority. She will be presenting today on getting Oregon's public use files to the public. And with that, over to Karen.
Good afternoon. My name is Karen Hampton. I use she, her pronouns. I work for the Oregon Health Authority All Payer, All Claims program as an operations and policy analyst. Today, I'm going to talk about our efforts to improve public access to the Oregon Public Use Files, also known as PUF. When I proposed this topic a few weeks ago, my hope was that we would have the files available on the Open Data portal. Then life happened, and we're still working to cross that finish line. However, I think we have some important information for you that I hope you will find very useful. In background, the Oregon All Payer, All Claims program was created in 2009 and has usable files starting in 2011. We have files for each year for medical and for pharmacy claims, along with membership files for those same years. We'll start our dental PUFs when we finish this process with 2019 data as the first year dental was collected in Oregon. PUF files are widely available, with the only limitation being that anyone receiving the files cannot attempt to re-identify individuals. There is a charge, but we're limited to recouping the direct cost of creating files. Files are large, even with the limited data fields, not large for an APCD file, but larger than many are experienced in storing and analyzing. So APAC is functional for public use files. Why put in the effort to change how we do it? There are two viewpoints, both of which support changing how our PUF files work. In our altruistic viewpoint, we have our assumption that making people aware of APAC will increase use of data in decisions and proposed policies. Also, and this is relevant to why we are not only putting out more Tableau reports for public use, people don't always trust the conclusions we reach with objective data. They don't like the questions we chose to answer. They don't trust the groupings we've chosen to use. If they had the capacity, they would want to run the data themselves. Helping them test our data builds our credibility as a transparent agency and as a scientific analytic team. The second viewpoint for change is more concrete and practical. We're using more resources than we're recouping. The timing doesn't work for students other than those doing theses and dissertations, and the files are too large for class room use. And finally, a platform has become available to host the data files. Underlying each of these is the recognition that simply making PUF files available for request as huge files with primarily academic descriptions of data limitations is insufficient in meeting our public obligation. The legal challenges we face in increasing and changing our public use files are no different than other APCDs. We must maintain confidentiality. We must find someone who will sign off on the data that we're producing as sufficiently de-identified if using less than the full safe harbor guidelines that are in HIPAA. One of the issues with using statewide data as is recommended in HIPAA for fully de-identified files is that Oregon has a great deal of geographic diversity. We have the I-5 corridor where the primary population centers exist. We have the coastal regions that are isolated by a mountain range, and we have Eastern Oregon, also isolated by a mountain range. The resources in Eastern Oregon or central coastal Oregon or the I-5 corridor cannot really be distinguished when you have a public use file that's statewide, so it has very limited value. It can be useful for students in learning how to use the data and learning how to use AI, but if someone's really looking at it to make policy recommendations and understand what's happening in the state, it confuses and masks issues that some in our state are experiencing. So we want to move to less than statewide data, smaller geographic region than statewide data. Next, we have the technical challenges. Again, these are the same as any state probably has. The files are very large. We have to have the determination that's de-identified both for our leadership in order to get approval for releasing the files and from our security IT for approval and posting the files. And prior to the availability of the open data portal in Oregon, we didn't have a place to stage the files that could take them of that size. Size is still an issue, even at the open data portal. We'll probably be breaking the files into numerous smaller files and posting instructions on how to rebuild those files into a single analytic database for tools later on. The other consideration is social license, particularly in pursuit of health equity. I believe this slide is really the crux of our motivation. Social license not only limits how we share the data, such as protecting confidentiality and privacy, particularly when data is collected without explicit permission. It also pushes us to make the best use of the data and to use it as fully as we can while still honoring that privacy for the individual. We need to see the value of the data that we have received and make sure that we're using it. We also need to stop being the ones who have to know the right questions to ask. This is very hard for someone who has spent their career in government working hard to do the right thing to help people at the right time. To stop and acknowledge the best help might be to get out of the way and to let somebody else decide what the question should be, what the analytic process should be, what the publication should be. Our role may become more of a stagehand where we're trying to be supportive of others doing the work and remaining inconspicuous while making sure that everything still functions safely. Finally, this will never be a data set that can be analyzed in Excel or MS Access, but removing the barriers we can, including file size, cost, and delay in access, strengthens our agency and the usefulness of the data. So here we have the nuts and bolts. What is the PUF process currently? As you can see, it involves a minimum of 4 staff and generally a minimum of 3 weeks. As I said earlier, the state recoups the direct costs, but eats all the staff time and administrative costs over and over each time that we release the data file. For those who prefer a visual representation, this is the Visio of our current process. It's 13 steps, and I have oversimplified at the handoffs. I'm sure that fiscal services, the research analyst, and the staff member who handles the SFTP process all have several steps on their own as well. So compare this process to the proposed one, 4 steps, 1 person, the data requester does it all. The state does eat the direct one-time per file cost of creating the files, but avoids the recurring costs and has the benefit of immediate availability. So what do we still need to do to make it to those 4 simple steps to get data? So one of the things we need to do is focus on the functionality. This includes what files are we going to create? How are we going to break them up to be of usable size that can then be, if needed, reconstructed to still provide a full state profile? How often should we renew some of the files that we create? What topics should we control? Should we do type 2 diabetes and hypertension? Should we do other ones? Should we do type 2 diabetes each year? Should we try to do a 3-year file and renew it in another 3 years? What is going to be useful for people? And then, as I said, how do we get a full year of data that's too large to post as a single file available for people who really do want to look at the state as a whole? The next thing we need to look at is the usability of the file. We need to give good instructions for the data download. We need to have instructions for using the data at the 5,000, 2,000, or 500 foot levels, recognizing that the audience is not going to be a one-size-fits-all solution, even though the data we are handing them is attempting to be a one-size-fits-all solution. We need to give them background on APAC that's not directed to professional researchers, but is still scientifically credible. We're giving them all the information they need, but we're giving it to them in a manner and at a level that makes sense for their use of the data. Finally, I would like us to provide some sample code in R, which is the most common software that we've seen coming into the state for data analytics, where they can at least verify the contents of the files and get a feel for how they can use those files. The other area that's going to be quite near to us is sales. And by this, I mean our communication plan. We need to develop our sales pitch to include data provenance and curating the data for the subject area, including good tags for effective searches. If people can't find it, we're not benefiting anyone by posting it online. So all of these things are essentially good librarianship, and we need to learn how to do that since this is something that's going to be new to us. We will be starting small and then trying to grow over the coming months and the coming years, improving our tags, improving the information we're providing about the data provenance, including where did the data start? How many hands has it passed through? What are the different manipulations that it's gone through in the some of the computed variables that we may make available to them? So all of these are going to be areas that we're not only going to be trying to do ourselves, but reaching out to community, to students, to professors, saying, please help us make this better data and more useful for people, so that the APAC data or APCD data is actually in the community making good things happen. So that's where we are right now. I want to thank you for your time this afternoon. Here's my contact information. I'm very happy to answer questions at the end of these presentations or at any time in the future if you want to email me. I also have included the APAC admin general email as well as our general webpage. So thank you for your time.
Awesome. Thank you, Karen. Are there any questions from the audience at this time? Not seen anything yet. So yeah, Karen, I was wondering, I think it was on slide 7 when you were talking a little bit about giving up control and how that can be, a bit of a tricky and difficult process. Wondering if you have any tips or advice for states that, maybe are trying to build out this process right now and are thinking about the best practical way to get that going. How does one go about giving up control?
I do think that we really need to look at having a balance, because we don't want to give up control total where someone could misuse the data. We still want to make sure that the data is being used appropriate to what the data content is, and not just let people loose with it completely. However, very often what we found here in Oregon is that a lot of community groups that have been underserved in the past or hurt in the past by official state policies don't trust the questions we ask, so don't trust the answers. So I think that's really what I want to get at is just because we think there might be a better question doesn't mean that's the question someone needs to answer, because that might not be their concern. Just because we think it fits the data, not all questions should be driven by the data. If the data is not useful for the question, then we need to tell them we don't think our data is going to be useful to answer that question. But if we say, well, our data is going to be useful for that question, sort of sideways. If you look at it in this way and you combine it with something from the census, or you combine it with data from other sources to try to get a profile before you do any interpretation. One of the things that's been very hard for us is trying to trying to understand how we can match up with qualitative data, which is often of more interest to community groups. But if you just have the qualitative data and you don't have the quantitative data, then it takes a long time to know if you're making progress. And most programs don't have 3 or 5 years to know if they're moving in the right direction. They want to know if they're moving in the right direction for a shorter time. So you have to figure out what quantitative information is going to give you that. But we're going to be working very heavily with our Office of Equity and Inclusion, which is actually a division here at the Oregon Health Authority that's titled Office, and work with them about, how do we interact with the community groups so that we're maintaining scientific precision, but we're not trying to shove them into academic boxes.
And just kind of as a follow-up, so you've mentioned a few of those community groups. Could you maybe elaborate a little bit on which groups you've worked with, or are there any that you would recommend to maybe people listening that they consider reaching out to in their states?
Well, one of the issues we're facing is that the Office of Equity and Inclusion is building a data set, as it were, of the different community groups across the state, and they have over 200 of them. So it's going to be a problem for us to reach out to 200 of them. So that's one of the things that we do want to work with the Office of Equity and Inclusion. Certainly, we want to be very respectful of our tribes here in Oregon. So any overlap with them, we would work through our tribal liaison, but work with the tribes and say, we're looking at doing this. Do you think this impacts your people in any way that we would want to coordinate, and make it open to them? And as sovereign jurisdictions, that's probably our top priority. But there are really a variety of groups. And as we move more for health equity from, and I hate using the word just, but just race and ethnicity, which are traditional areas of health inequities, and we move more into the intersectionality of it, where we do have LGBTQI plus groups, where we do have multiple ethnicity or as a social concept, groups that feel like they're on the fringes of things. At what level do we report so that their data can be seen without being so microscopic that we risk the confidentiality? So it really is very difficult for people.
I would imagine. All right. I think we have time for one more question. I see there's one in the chat from Jeff Stoddard. Not sure if we can pop that up on screen, but I will read it either way. So Jeff asked, are you aware of any interesting use cases of using the PUF within Oregon?
So the most frequent use of PUF that I'm aware of is actually market research. We're not allowed to use it elsewhere, allow it for market research for limited data sets. So that's certainly the most common use of our public use files. Even for our classroom settings, our students, they generally get limited data sets. We do have posted on our website, so if you follow the link in my last slide, you'll find it, a use case document that has all of the uses, and that does break out public use files from the limited data sets. But being a statewide data set is very limiting for our public use, because we're a diverse state, at least in economics, if not in other areas. And so it masks some of our issues.
Thank you. I will do one more and then on to our next presenter. So we have one more question from Hisa Hashisaka, who asked, what is the audit process on the agreement to not re-identify? There it is up on the screen.
Well, and currently for our PUF, because it is statewide, it would be extremely difficult, and someone would have to have a great deal of information in order to re-identify. So we do not have an active audit process. The most that we do is with the idea of it's an accidental potential re-identification, and that is that we request all data users, PUF or limited data sets, to show us anything they're going to publish before it goes out, so we can tell them if we think it violates the confidentiality provisions in the data use agreement.
All right. Well, thank you very much for your time, Karen, and we'll bring you back up at the end of our presentation session today if there's any final questions. But with that, we will move on to our second presentation topic for today. So up next, I would like to introduce Will Tesch from HealthLX. Will is here to present on closing the information gap for members and their caregivers. With that, over to Will.
My name is Will Tesch, and thank you for allowing me to present today at the NATO Association, a concept called composable automation, what it means and how it can help interoperability and data standardization. My name is Will Tesch. I'm the CEO of HealthLX. I've been in the industry of enterprise integration, enterprise strategy for the better part of 30 years. I continue to think I'm a student of the healthcare industry because it's a big, old, ugly problem that has to be solved. And I'm proud to be right in the middle of it, solving for some of the most challenging scenarios in healthcare today. Look forward to sharing with you what we believe to be a novel and important approach to overall enterprise capabilities with enterprise interoperability. Over the last 40 plus or minus years, there's been ideas that have contributed to solutions oriented toward making sure applications can talk to each other. That's basically what interoperability means. Certainly applications talking to each other, but data moving between applications to each other is another way of viewing it. We believe in 2016, fall of August of 2016, there was the introduction of an open source product, or a product that was introduced to the open source community called NiFi. Those familiar with NiFi know that it's a growing ecosystem inside the open source community. It originally came from the NSA, but that underlying technology has allowed us to look at interoperability differently, and notably different, because everything else prior to NiFi was written with a fair number of constraints in terms of agility and evolution, and you'll see what I get to in a minute. But all of this contributes to an idea which we believe is called composable automation. And some information on that is here. It's a type of platform architecture. All platform architectures are required to have four kind of fundamental ideas behind them. They should be simple. In other words, they should be describable with a certain amount of abstraction to what these platforms are capable of doing. They ought to be resilient. One aspect of the platform shouldn't shut the entire platform down. And the key here is that subsystems are become very important to how the overall platform works. These subsystems could relate to any particular nuanced capabilities, as in fire processing, APCD, data constructs, as an example. They ought to be maintainable. This is probably the biggest challenge with platform architectures over the years. It's that they've developed independent of the management layer for CPU and memory, and overall platform architecture was so important that it impacted how one looked at building a platform. The platform also ought to be able to evolve. We know one thing for sure, in all the years I've been doing this and the years that you have been doing this in the audience, you know that things change. Any number of things change, and the intent with the platform is to be modular so you can accept those changes. So what is composable architecture? Gardner says composable architecture is a framework that enables organizations to rapidly build new and existing business capabilities, products, and services. If you've been in technology long enough, you could probably say, well, that sounds like programming languages as an architecture. Well, it's probably accurate. Automation. What is our definition of composable automation? Well, we believe that architecture is critical and the approach to doing that is critical. But the automation means that you should have ideas like workflow design, operational oversight, and scalability core to that platform, hence composable automation. So I'm going to talk a little bit about workflow design, operational oversight, and not talk so much about scalability because this is a time-constrained presentation. And more intently, I guess I'll just focus on workflow design. So workflow design implies that there are components that you can create into a workflow. Those components we call purpose-built components, and purpose-built components in many ways are similar to coding concepts that are configurable. These coding concepts, there have been ideas throughout the years like SOA architecture, like object-oriented programming. In some ways, these are the embodiment of the best of those ideas, where we have purpose-built components, meaning configurable code that can be assembled in such a way that once configured and assembled, you've got a workflow that's described from a business viewpoint. So we're going to be talking about business process management, business modeling, process modeling using our platform. And I'll show you that in a second. All of this is built upon the dimensions of a PBC: composable thinking, composable business architecture, and composable technology. So these PBCs, purpose-built components, once grouped together, solve for any number of healthcare challenges, and frankly, outside healthcare challenges. So we have components that are grouped together to solve for data management, if you would, for CMS initiatives like the Patient Access API, for vaccine reporting to states. So these components, we once assembled together, can solve for any number of use cases that our healthcare is challenged with solving. EHR integration. Not every EHR, not every Epic or Cerner implementation is like the next, right? So you have to have this ability to be nuanced in your workflow design to support any number of these healthcare challenges. And you have to look at the problem differently. And we believe once you look at it with a composable viewpoint, you can solve for it from a composable viewpoint and also automate for it. So this is just one screenshot of our workflow editor. And our workflow editor, what's essential here to point out is everything on the right side of that palette, all those boxes with lines, those are all components. Those components are on the left-hand side in terms of like an inventory of components you can drag onto the palette and then configure once they're dragged onto the palette. This idea of assembly of business components to solve for any number of healthcare interop use cases is novel in its design. We're not familiar with anything in the market that's like this, but composable automation, composable architecture are still very new. We've been in production for since 2015 with our technology, so we're very excited about its future. The interoperability landscape, this is a quick and dirty picture. I guess it's colorful. It's probably not so much dirty, but anyways, it's definitely expresses at a colorful perspective the diversity of the challenges in the interoperability landscape. Some are driven by payers, some are driven by providers. There's code sets, all sorts of code sets that are necessary to be maintained and by the way, change and get added to. TEFCA's coming around. There's the APCD construct for all payer claims data set. The point is, there's this wide diversity of challenges in the interoperability landscape. I'm not stating anything new. This has been around forever, since healthcare interop started having applications talk to each other. There's been the need for interoperability challenges. So the way they get solved is the novel approach that we think is tied to composable automation. So here's an example. Just a real quick example, and I could spend a lot more time than I'm going to spend on this, but it's rather simple. And these ideas, by the way, have been around forever. When you look at an implementation guide for how data should be communicated to a party, that implementation guide is published, it's produced, the idea that everybody will adhere to it. Everybody's adherence to an implementation guide is no better an example other than EDI. There's been EDI implementation guides for 40 years, and every one of those implementation guides has a document structure that has to be adhered to, but is never quite perfectly adhered to. So you have ingestion problems with those documents. That's no different than the APCD approach. You've got multiple payers believing they're solving for and they're agreeing to and they're auditable against an understanding of a construct that follows the implementation guide of that construct. PBCs, to take the ingestion problem alone, knowing that they're not going to perfectly match, we should transform those constructs to something that will match. That's what transformation PBCs with an automation platform allow for an aggregated canonical. So as much as each of those ingestion processes a payer, and those ingestion processes might be slightly different than the next, they all become validated and transformed to meet a canonical that's required for the state. Those boxes on the bottom kind of describe today's process at a very high level. I hope to talk more about this in Q&A, but the long and short of it is our approach to composable automation is not just ours, but it's a movement that's happening in the industry. If certain principles are adhered to, we believe that the industry can evolve quicker, with more agility and be much more successful, as the healthcare industry needs successful implementations of interoperability. That's it. Thank you very much. I know I crammed a lot into this very short message. I'm looking forward to the Q&A. Thank you.
Awesome. Thank you, Will. So I have to start off by saying my apologies to Will that I had my notes wrong. The title of his presentation, as you just heard, was Composable Automation, What It Means and How It Can Help Interoperability and Data Standards, and not what I said at the beginning. So again, my apologies to you.
No worries, Jen. It was certainly different than
you didn't know what you were in for today.
Yeah, got a little geeky anyway, so
I like it. I had a question to kind of kick us off that, as a non-super technical human being, hopefully is a sensible question to ask you. But notice that, one of your slides, you had mentioned, one of the usability cases for APCDs could be around like CDL validation. So just thinking, if I'm maybe a state that's been doing data collection with our own kind of, unique standards and our own data layout and data guide, and I want to move to the common data layout, is composable automation, is that something that could maybe help me with that process?
Yeah, absolutely. I mean, in many ways, what you're describing is an age-old problem with any kind of data transformation, right? It's the interpretation of the semantic, like how closely am I adhering to what is supposed to be told, so that somebody hearing what I'm telling can be effectively heard, right? This is very simple communication, but very difficult when it comes to digital data exchange, right? So absolutely, the transformation layer becomes something that has to be nimble, because no matter what you read, and I use that EDI example, but it's applicable across a whole bunch of different transform ideas. But as much as you can read what you're supposed to develop or build to, most oftentimes are not accomplished, especially at the bigger the community, right? So therein lies one of the biggest challenges in healthcare, the semantic layer, right? So yeah, for sure.
Awesome. Right. Do we have any other questions from the audience at this time? Not seeing anybody yet. Oh, there's our little note at the bottom. All right. Will, any final comments or suggestions, tips or tricks you want to add for the audience?
No, other than I guess just to overstate what I said, and maybe in a more simpler fashion, but healthcare needs semantic clarity to execute. People have historically said, "Oh, we'll never get there," but FHIR is really the introduction of one language that both payers and providers are adhering to, and it's being enforced by CMS. So what does that mean? What does that say? That says that the country is saying, listen, you guys, providers and payers, you have to talk in the same language. And that's going to remediate a lot of the issues you have today. So, we see a lot of hope in the FHIR construct and the path. So that's something I think everybody should hear, payer or provider.
Well, thank you. All right. So we have one question in the chat that we'll get, I think, hopefully brought up on screen here in a second, from Betty Harney. Can you use composable automation to version medical or pharmacy claims? Do you have any experience doing that?
Yes, we do, actually, and most definitely. It's back to data transformation. So we are doing a lot of different transforms in and out of FHIR. Funny enough, even with EDI, having to translate EDI constructs into FHIR constructs. This is definitely a movement in this direction. So versioning, the whole concept of versioning code sets or versioning data constructs that are kind of agreed to, like USCDI version 1, version 2, etc. Big deal, right?
Awesome. And Betty just offered a clarifying statement as well, stating that by versioning, I mean identifying the most recent version when there are multiple versions of the same claim.
Yep, Yeah, absolutely. That can be done in the data transform and oftentimes in the metadata layer of those constructs. Some of the versioning information is made available to allow for whatever transformation path needs to be considered. So, yep, absolutely.
Great. All right, thank you, Will. So I think with that, we will move on to our third presentation, and Will be available. Oh, there's one more question that just popped up. Sorry, just kidding. Sorry, Charles, just messing with you here. The question is, how are payers or providers communicating using FHIR? What are the implications for claims transactions which currently exist outside of FHIR?
Yeah, so first question, how are payers and providers communicating using FHIR? Well, I'll tell you, there's an obligation by payers to accommodate a CMS rule that came out in March of 2020. And that rule basically said that all payers have to communicate to patients their clinical data and claims data in a FHIR format. So the country has done that, to the degree that all payers are compliant, still an open question. In fact, there's an argument to suggest that there's not a lot of momentum pushing on payers because enforcement isn't really occurring. But anyways, they are already converting data to FHIR so that consumers can get their data eventually when there's going to be some kind of enforcement. So what are the implications for the claim transaction, which currently exists outside FHIR? Well, let me tell you, the claim transaction itself, the United States is one of the few countries in the world that mandates all payments or all healthcare claims, if you would, all are handled via 830, HIPAA transactions, EDI HIPAA transactions. So we're the only country that does that in the world, right? So the other countries all over the world are implementing the same kind of constructs, but in FHIR. So we're beginning to see the U.S. Large payers also evaluating how they're going to move in and out of FHIR with EDI transactions. Hopefully that answered your question.
Thank you. All right. So now for real this time, Charles, that's our thank you again to Will, who will be available at the end if there's any final questions. But we will now move on to our third and final presentation for this session. So last but not least, pleased to introduce Jennifer Harper from the Oklahoma State Department of Health. Jennifer will be presenting today on Oklahoma's Hospital Discharge Program Data Modernization, design and implementation of a technical solution intended to enhance data quality and completeness. So with that, it is over to Jennifer.
Good afternoon. I'm Jennifer Harper, the Administrative Program Manager for Data Acquisition in the Center for Health Statistics at the Oklahoma State Department of Health. I'm here today to talk about Oklahoma's Hospital Discharge Program Data Modernization, supported by a custom technology platform. This solution was developed to reduce reporting burden on facilities while enhancing data quality, completeness, and timeliness. The Oklahoma State Department of Health began using technology to automate data collection of hospital discharge data roughly 24 years ago with a custom-developed application that reached its end of life in the summer of 2021. Planning for a new data collection platform began shortly after the CDC launched its Data Modernization Initiative. As we began research into current technology to replace the legacy system, Priority 1 of the CDC Data Modernization Initiative became a cornerstone for the scope of program design. Priority 1 of the CDC's Data Modernization Initiative focuses on foundational infrastructure. Several components of this priority address challenges faced with hospital discharge data collection in Oklahoma. First, the application would need to be readily scalable to address the increase of discharge records collected across the state. Oklahoma began collecting discharge records in 1998. At that time, only inpatient discharge records were collected. Since then, reporting of outpatient surgical discharge records, ambulatory surgery discharge records, and most recently, emergency department discharge records became mandatory. As a result, reporting grew from around 400,000 discharge records in 1998 to the current projection of 3 million records for 2022. Towards end of life, the legacy system demonstrated marked decrease in speed, and in some cases, database tables needed to be disaggregated to support reporting and analysis due to the amount of data collected. As a result, scalability of the new application became a critical component to prepare for the future expansion of data collection. Second, reducing burden on data providers was highlighted as a key characteristic for the new application. We had received feedback from facilities that the legacy system was difficult to navigate, frequently crashed as a result of the increased volume of data, and that other state health departments had a more modern user interface supported by sufficient computational power that saved the data provider time and frustration. In anticipation of the legacy system reaching end of life, the Oklahoma State Department of Health issued a request for information to explore the possibility of contracting hospital discharge data collection. Response to the RFI was lower than we had hoped, though was informative of available capabilities for those that did respond. Stakeholders, including hospitals and vendors submitting discharge data, provided valuable insight into needed functionality. Stakeholders that submitted discharge data to multiple states provided insight into features offered by other states that were particularly helpful when submitting data. Discussion with members of professional associations deepened our understanding on what worked and what didn't in similar projects. The NATO community were especially insightful partners during the project planning. Ultimately, it turned out that building a custom application to facilitate data collection was the best fit for the Oklahoma State Department of Health. This decision was made by weighing needed functionality with the direction provided by the CDC's Data Modernization Initiative and cost. On the next 2 slides, I'd like to talk through some key technology-driven improvements that can be seen as a result of this new application. The state developed a partner portal, which facilitates secure online data submission from facilities to the Department of Health. In many cases, facilities report data to more than one department in the agency. The partner portal collects not only hospital discharge data, but also data reported by facilities for other departments across the agency. This reduced the number of online platforms data providers need to use and provides facilities with an intuitive user interface. In this screenshot, I am logged in with authorization to submit hospital discharge data. The status of my recent data submissions are shown in the right-hand column. For authorized users who submit data to other departments for the agency, additional links for each program are displayed in the left-hand column. For facilities reporting multiple data types, this provides a single user interface with intuitive navigation across programs. Data collected through the partner portal is routed to the appropriate database. Facilities have additional options for submitting their data other than the partner portal. Data may be submitted via API or the State Health Information Exchange for facilities with the technical capability to do so. These automated data submission methods take advantage of data collection methods used for other programs for the Department of Health, further integrating services and further reducing reporting burden on facilities. Once hospital discharge data are submitted, they are automatically validated and feedback is provided in near real time. Each data row with an identified error is displayed on screen in what we call the error grid, as seen on this slide. Corrections to misentries can be made by entering the corrected value on screen, or the facility has the option of resubmitting their data. On screen, we can see in the 3rd row the value of U, or undetermined, has been highlighted red. The facility has a maximum of 2% of missing and U values. Should the percent of values in error exceed the allowable 2% by the time the error correction period closes, facilities are considered non-compliant. Each discharge record is reviewed for out-of-range values, missing entries, and invalid codes. Critical entries, such as patient date of birth and gender, allow up to 2% of inaccurate or missing values. Oklahoma has a strong history in data completeness, partially due to the error correction feedback. Also, facilities that do not submit data, do not make corrections to their data, or have greater amounts of errors beyond the acceptable percentage are sent a letter indicating they are non-compliant with Oklahoma state law regarding hospital discharge data, which is carbon copied to the licensure department. As a result of the near real-time display of errors, facilities have access to their error grid nearly 2 months sooner than the legacy system. In the legacy system, reports for each facility needed to be generated, then upload to a secure data shell to provide feedback on the submission. Facilities in Oklahoma have 30 days after receiving their error grid to complete their ratings. Through automation, the processing time of quality review is shortened by 2 months, allowing facilities to finalize their data much sooner than before. Timeliness of data dissemination is also improved. Discharge data that is submitted is immediately uploaded to the database. Filters are set up to allow data to replicate to other program areas as it is collected. Therefore, other program areas within the Oklahoma State Department of Health have access to data as it is submitted. As the development phase of the Hospital Discharge Data Program application ends, we have been provided an opportunity to reflect on aspects that worked well and program development that could have been improved to apply this learning to future data modernization endeavors. One challenge the team faced during the application development were delays. This application took more than a year to develop, with the majority of delays occurring in the initial planning phases of development. These delays appeared to be related with establishing a common understanding of the program's functionality and the required infrastructure across the development team. The development team included project managers, programmers, database administrators, security and compliance specialists, as well as quality assurance personnel. In retrospect, team turnover, coupled with the complexity of hospital discharge data collection, resulted in frequent repeat discussions regarding desired capabilities of the program. Additional planning efforts before launching the development of the application may have been useful, such as storyboarding the desired program functionality, advanced preparation for agile sprints, and project owner-defined success criteria for milestones. These are helpful reflections that we plan on applying to future data modernization initiatives.
All right, thank you, Jennifer.
You're welcome.
So again, if anyone has any questions for Jennifer, please put those in the chat. And I'll kick us off, I guess, with one question that I had listening to your presentation. You had mentioned when you were, sunsetting your old program and trying to design the new program, that you received the feedback that some other states had maybe a more user-friendly UI that was maybe a little bit more easy to navigate. Just wondering what steps you took when you were trying to make sure that your UI was really as user-friendly as possible.
We took a couple of steps. The first was really, we have to share the credit with the design team and the engineers that started the development. They started the footprint using some more modern platforms that are available, that are both contemporary as well as intuitive to use, because you'll see some of the similar elements on other widgets online should you be using different platforms. And so we had a really good head start with that. From there, we are doing some demos and collecting feedback. We collected feedback before about what people liked about some of the other platforms, and that was really helpful. And we were able to share that with the engineers so that we would get as far as we could in the initial build, but also collecting feedback now that it's rolling out and still have enough time to make some minor tweaks if that's necessary. And that's also part of our change management strategy to orient some of the facilities to some of this new technology that's coming out. Not only can we incorporate their feedback, but we can also help them get their feet wet with it as we get going.
And what have you felt that the facilities, as you've been rolling this out, have they generally been pretty receptive? Are you getting some of the, technology pushback that we see with change sometimes?
Well, we're anticipating some of that resistance yet, but those facilities that have volunteered to assist with some of the piloting, they volunteered personnel, they volunteered data. We've had a really warm reception. And so we do have one person on our team. His name is Finney. He's very actively involved in maintaining the conversation with each facility. And he brings it up and has a lot of informative discussion, two-way dialogue, really, that helps bring people along. And we're hopeful for the future. And I'm sure in future we'll be able to report back that'll limit some of the resistance.
There you go. So anybody who's maybe looking to do some UI updates, get yourself a Finney, but don't steal Finney from Jennifer. And and it sounds like, ask for volunteers is maybe a good tip. Let the facilities feel like they're maybe doing a little bit of a public good by volunteering and helping you out. And then they obviously get a better end product as well because they get some input. Amazing. Any other questions from the group? Not seeing anything from the audience quite yet. Jennifer, any final comments or suggestions that you would have for any other states considering similar work?
In developing a new platform change is a big undertaking. And thinking about how to either future-proof or integrate with other new technologies that are being put into place, I think is really key to driving some sustainability and ensuring that the data are interchangeable and can be connected later on down the road. So putting some thought into that, I think, is very helpful.
Awesome. Right. And we have a question in the chat from Kenley Money. There we go. It's up on the screen. So with these UI and data intake improvements, is the department able to turn analytic data around faster? We have found the data source from states based on departments of health are as much as 2 years old.
That's one of the things we're most excited about transitioning to this new platform. We can collect data faster, and data is being populated into online databases for each of the analytic groups that have access to discharge data in near real time. And so we've shortened the data collection process by roughly 2 months by eliminating all the manual steps and the human intervention and review of the submissions that come in during our feedback loop. And that way, facilities, as soon as they upload their data, they have the opportunity to make corrections, and then that correction time period closes. So there isn't that waiting period on the state. As soon as, from an analytics perspective, as soon as the data is uploaded, it is available in our hospital discharge overall database. But the parts that are applicable to different departments get replicated immediately into their databases. And in doing so, they have access to both the corrected data, or should they want to access data within that 30-day window that facilities have in order to make corrections, they can access the raw data or they can access the corrected data pretty much as soon as that it's uploaded by the facility.
Awesome, thank you. All right, so we have about 5 minutes left in total in this session. So I will also open up the floor to the entirety of the group. So if anyone has any final questions for Karen on their PUF program in Oregon, for Will on composable automation, or for Jennifer on modernizing hospital discharge data, now is your time to ask. Right. Not seeing any final questions at the moment. So with that, I will hand things back over to the wonderful Charles.
Thanks, Jen. And thank you for organizing the session, and thank you to all of the presenters. I thought it was really, really interesting. I think I mentioned in the last session that we've spent a fair amount of time here at NATO during the Spotlight series, thinking about health inequity and disparities. In fact, if you want to see the Spotlight series videos from this summer, they're available on demand on the conference platform. But we get into some of the topics addressed by addressed by Karen, and also thinking about somehow the interoperable standards might be useful to collecting better or more complete data in the future for public health. And then lastly, Jennifer, I'll say that I really appreciate you and what you're doing. I've modernized the hospital discharge data system before, and it's hard work. So thank you all for taking the time to join and share your experience with us. I really appreciate it.